Here's a 69-year-old woman, and she had left kidney area pain. And this was her left kidney, and notice there appears to be some thickening or asymmetry in the mid-kidney. So the question was, is this a mass? Well, we had no other comparison imaging, and so we did ask for a CT in this case, or excuse me, an MR. And what did we see? In fact, there was no abnormality. This was a normal column of Bertin. And column of Bertins occur in 6% of adults. One of the ways to differentiate column Bertin from abnormal renal masses is the fact that there's no outer contour abnormality. Here's a 71-year-old man with chronic aortic dissection. And in the kidney, we notice this sort of echogenic area. So is it a mass? Is it scarring? Well, when we looked at the patient's previous CT scan, we noticed that in fact there was some thinning here. And this is just, again, a congenital abnormality. It's junctional parenchymal defect. This is a fusion defect when the anterior and posterior ranunculi of the kidneys fuse, and it's located anterior and superior in the kidney. So if it generally it's in the junction of the upper 1/3, lower 2/3 of the kidney in the anterior aspect. And if you see that, think junctional parenchymal defect. Here's another patient, unusual looking kidney, sort of sticks out here. Has renal arterial flow. Is this a mass? Well, luckily, we had previous imaging available, and this unusual lobulation had been present for 7 years, and this is just a fetal lobulation. 65-year-old man with back pain, and this is the left kidney. First of all, this is not a normal kidney, right? This very echogenic kidney. But in the lower pole, there's a hypoechoic mass. So is this a renal cancer? Well, it turns out in this person that it's a heavily calcified lesion, which turned out to be renal TB. So this illustrates the fact that benign lesions of the kidney really are indistinguishable from malignant ones. This is a 93-year-old man. He had just had renal lithotripsy earlier in the day. He went home and then came back through the ER. When we saw him that night, this is the way his right kidney looked, and there was a big mass in the upper pole. Well, is this malignant? Is this benign? Well, again, the renal history is very important, and in fact, this was just a large hematoma which had occurred as a result of renal lithotripsy. The 66-year-old man had a cyst on the CT, and the cyst on CT was too small to be characterized, so this patient was sent for ultrasound. Well, on ultrasound, we found that the mass was hyperechoic and exophytic, sort of difficult to see the borders. So what do we say? Is this benign? Do we think this is an angiomyolipoma? Well, you know what? It didn't have fat on the CT. And so the borders are ill-defined, at least, possibly irregular, and in fact, this was renal cancer. Another patient, 63-year-old with postmenopausal bleeding, and incidentally, we noted this well-circumscribed echogenic mass. This incidental finding. What do? Well, in this case, we had no previous imaging, and we felt that even though it was circumscribed, that it was important to take a look at it with another imaging modality. In fact, it was not fatty, and it turned out to be a renal cancer. Here it is, the intraoperative image of that cancer. 55-year-old man with history of renal stone. And here we have a circumscribed mass, exophytic mass, no color Doppler. Well, do you think that this is a cyst? In fact, it turns out to be solid. People who saw it the day of the ultrasound made a good call, and it was sent to CT, and that was a renal cancer. 71-year-old woman. Now, this really did look like a cystic mass, and so the question is, do we just pass it? Does she need any other follow-up? Well, notice that this cyst is irregular in contour, and that some of the septations are thickened. And as a result of this, this patient was sent for a CT, And those findings were confirmed, and this turned out to be renal cancer. And so when we're looking at cysts, it's important to remember the Bosniak criterion, in which if we're going to not follow up, really we're thinking about cysts with 1 to 2 thin septations and a thin wall. Any other deviation, and then we have to really think about it. The Bosniak F category, 2F category, there are more thin septations and there may be some calcification. Anything beyond 2F, though, definitely needs to be worked up. Here is a 59-year-old man with right upper quadrant pain. And again, is this a renal cyst? It sort of has a hyperechoic rim. Cystic center, is that something we're going to pass? Well, no, it's not completely simple, right? The wall is not thin. This turned out to be renal cancer. Well, before I end this talk, I'd like to discuss a topic which I think is really important, and that is a new technique, relatively new technique, which I think will help us in evaluating renal lesions. And this is ultrasound CT-MR co-registration. It's now available on all major vendors, and it's, I think, a very important technique because it really allows us to be more operator independent. What this technique does is it allows the ultrasound machine to download a previously obtained MRI or CT and then to superimpose that CT or MRI data on an ultrasound. The CT or MRI images are reconstructed in real time in the same orientation as ultrasound. Well, what are the applications? Well, the first thing is if you're a teaching institution, it's a great teaching tool because many times residents are not as familiar with ultrasound cross-sectional anatomy because our anatomy is skewed. You know, we can look at organs in many different angles, but they're very familiar with CT or MRI anatomy. So if they have them side by side, it's much easier for them to understand and learn ultrasound anatomy. Secondly, just as a very practical aspect of day-to-day work, it's a great way to document lesions. And when lesions are documented this way, as a radiologist, you don't have to double scan because you know that the sonographer has been examining the correct lesion. Thirdly, let's say you have a very difficult case. You're sent a case in which there's some abnormality on CT or MR, and you're asked to characterize it by ultrasound, something like a very subtle renal lesion. Well, many times these are difficult cases, and unfortunately, my sonographers may not be able to find the lesion, and so it means that I have to go in the room. And since I'm busy, it's really important that I don't take a lot of time scanning. And having this technique really does cut down on the scanning time of anybody who has to cross-correlate between subtle CT and MR lesions and ultrasound. And then finally, having this technique and using it to document your exam really helps you communicate better with your referring physicians because just like residents, referring physicians many times can't read ultrasound, but they can read or understand a CT or MR. So when you have these pictures side to side, that is the CT next to the ultrasound, then they can understand that you have actually looked at the correct area.